So you're very welcome, everybody. My name is Gráinne O'Leary and I'm Chief Executive here in Arthritis Ireland, and you're very welcome to our first webinar for National Arthritis Week 2024. And our whole theme this year is about myth busting. In relation to arthritis. So today we're having Dr. John Stack speak about the topic of arthritis is not just an older person's disease. And before we start that, I just have a few slides here just to talk through what we're doing during National Arthritis Week. So each day this week, we're addressing 5 prevalent misconceptions associated with arthritis. So that will keep you guessing as we move through the week. And obviously the goal with that National Arthritis Week, and this week is no different, is to raise awareness and empower individuals with the knowledge and skills to better manage their condition. And with this in mind, we'll be running 2 additional webinars following on from today's webinar. Tomorrow at 12:30, the webinar will be on the topic of physical activity, exercise and arthritis, busting some common myths, and that will be delivered by Professor Helen French from RCSI. And then on Thursday at 12:30 again over lunchtime, we will have Louise Reynolds, who is a registered dietitian, speak about arthritis and food, everything you need to know. So if you haven't registered for those webinars, they will be separate links to today's one. So please go on to arthritisireland.ie to register for those webinars. And just in terms of our background for today, delighted to have Dr. John Stack with us, who is a consultant rheumatologist and general physician at the Mater University Hospital here in Dublin. This webinar is all about dispelling the myth that arthritis is an older person's disease. And John is going to discuss some of the more common types of arthritis, the signs and symptoms and the impact on daily life. He'll also discuss treatment goals and multidisciplinary care as well. Okay. A little bit, if it's your first time tuning into us and you're not too sure about Arthritis Ireland, what we do, just to say to you that we're a national charity and patient organisation for people living with arthritis all over Ireland. And we deliver a range of supports, training, education and information. We have a free national helpline, which is open Monday to Friday, 10 to 4 for support information, and also to register for the variety of programs and courses that we run as an organisation as well. And just to remind you about the number there. So the helpline number is 0818 252 846. So you can call that anytime between 10 to 4, Monday to Friday. Also, variety of information available on our website, arthritisireland.ie. So whether it's information on your type of arthritis, whether it's lifestyle and wellness information, or indeed to link to some of our resources in terms of our information booklets, videos, etc. You'll find all of that on our website. We do, of course, as a national charity, rely on the generosity of the public to ensure that we can continue to provide all of these essential services and supports to people everywhere in Ireland that are living with arthritis. And there's lots of ways that you can show your support this National Arthritis Week. So one thing you could do is make a one-off donation, or indeed a monthly donation. So if you would like to do that, you can scan the QR code that's on the screen right now. Or you can alternatively visit arthritisireland.ie and you will see the donate button on the homepage as well. We're also looking for fundraisers to take part in the VHI Women's Mini Marathon this June. It's on Sunday the 2nd of June. I myself am taking part on that day. So I am looking for people to join me, and if you are interested in joining me, it's a 10K, either a walk or a jog. So many people walk it. So we'd love to see our Arthritis Ireland community there on the day. So do think about that and register at arthritisireland.ie. And just a few housekeeping things before we kick off the talk. So everybody, both the presenters and the speakers, are on mute, and we've turned all the cameras off as well, which would be normal practice on a webinar. If you have any questions, do put your question in the Q&A function in Zoom. So just type it in there, and my colleague Tara is going through, and we'll be monitoring those questions as we move through the session. We've allocated 30 minutes for Q&A. So, you know, we have a good bit of time left, but just do remember, it is in relation to what John's going to be speaking about, and in terms of the topic at hand today as well. We will do our best to respond to as many questions as possible within that time allocation as well. And of course, the webinar is being recorded and will be available as well to view on our YouTube channel after the event, okay? So if people would have liked to have tuned in, they can watch it back shortly after the event. And thank you very much for your attention. There's just our website information again, and our helpline number as well. And without further ado, I will invite John Stack to start his slides there. Thank you very much, John, for being with us today and giving up your time.
Yeah, thanks, Grania, for the introduction. Just get the screen out of the way. Yeah, so I've been asked to give a talk on debunking common myths, and the myth that I was asked to debunk is that arthritis is just an older person's disease. When I was preparing for this talk, I was thinking, you know, how does this myth come about? And when I think of, say, for example, rheumatoid arthritis, I was thinking, well, who are the famous people that I know that have the condition that might be, you know, maybe representative of, say, the disease? And the first person that came to mind was Edith Piaf. So I'm sure many of you will know who Edith Piaf is. She's a famous French singer. And sadly, she had rheumatoid arthritis at a time when there was really very little treatment available, except for corticosteroids and strong painkillers like opioids. And she had quite a tragic life, and she had, by the end of her lifespan, she had severe deformity in her hands and feet from untreated rheumatoid. She had steroid toxicity. She developed multiple spinal fractures from steroid-induced osteoporosis, and she was largely confined to a wheelchair. And she had a number of heart attacks, and I think she died from a heart attack ultimately, and her cardiovascular disease would have been caused by her underlying rheumatoid, because we know that untreated rheumatoid arthritis and other types of inflammatory disease causes accelerated cardiovascular disease. And if you were to see her in the latter stages of her life, you would be forgiven for thinking that she was an elderly lady, but actually she only died when she was 47. So she was still quite a young woman, but she had aged prematurely, and that is what the disease did back then, before we had advances in therapies. So I think there are probably other figures like her that kind of maybe paint a picture that rheumatoid is a disease of older people. But in fact, it starts much younger than that, and it affects a wide range of people. And this is another gentleman. This is he's an American sports presenter. His name is Matt Iseman. I don't think he's as well known here. He's a former athlete, and he developed rheumatoid in his 40s, and he has been a very public advocate about his disease and the challenges that he's faced and overcome. And I think he has helped to kind of broaden the awareness that arthritis can affect, you know, anyone really of any age and sex. Phil Mickelson is a golfer who has achieved great success despite having psoriatic arthritis. And again, was very important when he was public about his disease, because it illustrated that you can have a disease like psoriatic arthritis and you can go on to still achieve your sporting goals in golf as he has done. And also then Venus Williams, who has Sjogren's syndrome, and has been also very public about the challenges that she has faced and overcome, and managed to pursue success in her tennis career. So to summarize, why does the myth exist? I think the myth exists because public perception is often informed by popular culture. especially nowadays, the physical signs of arthritis are not often visible during the early phases of the disease. And it's only until patients are much older that they can develop physical manifestation of the disease if they've had it for a long time. And that is becoming less and less that they will show signs of damage because of the treatments are so good. So arthritis can be invisible until damage becomes evident. And whilst the prevalence of arthritis does increase with age, it often starts when people are much younger. And untreated arthritis causes premature aging. So I think all of these factors combined kind of have given rise to this myth that arthritis is an older person's disease. So why is this a problem? Well, I think it can create a false narrative about the disease. So if people think, including patients themselves, think that arthritis is an older person's disease, then they might just, think, well, I'm not going to do anything about it because I'm just getting old. Or other people might look at somebody with arthritis and say, well, you don't look old to me, you couldn't have arthritis, or you look fine. And this then can lead to kind of poor self-management, feelings of isolation. It might cause a patient to delay seeking treatment. And if it contributes to poor insight and poor understanding from employers, friends, and family, then they're not going to be best informed to provide the support that potentially they could give if they had a better understanding of the truth behind the condition. This was an article published in the Irish Independent last year about a patient who is now in her 30s, but had struggled with juvenile form of arthritis from a very young age. And she was reflecting that when she was much younger, she didn't really feel heard about her disease. And she kind of played down her symptoms because she didn't want to go on medication. And she just talked about how the perception that arthritis is an older person's disease, but that did not ring true for her when she had the disease from a very young age, as far as like 6 years old. And thankfully, I think pediatric and adolescent care of arthritis has advanced a lot in recent years. And I'll talk more about that in later slides. So arthritis is most definitely a disease of all age groups. This is a graph taken from the Global Burden of Disease study. So this is an international epidemiological study where they've looked at a number of diseases across all specialties. And this particular study has focused on musculoskeletal disease. So on the left here, you can see this was the burden of disease of musculoskeletal disease back in 1990. And you can see that as far as 2019, the cases have almost doubled for all types of musculoskeletal disease. And contrary to what you might think, most of the cases are not in this age, the older age bracket. Most of the cases are in the middle age bracket and perhaps even the younger bracket of teens and 20s. Okay. So I'll just speak through some some diseases and just talk to you about them and kind of provide information to support the notion that arthritis is a disease that affects all age groups. So rheumatoid arthritis is one of the commonest forms of inflammatory arthritis that we treat. It's a systemic polyarthritis, which means that patients have systemic inflammation, and they also have arthritis that affects multiple joints. Most commonly, it affects small joints of the hands and feet, but any joint can be affected. The prevalence is about 1% of the population, and it most often starts in the age range of 25 to 40 years of age, but it can start at any age, from someone who's in the first few weeks of life up until their 90s. It has a female predominance of about a 3-to-1 ratio, and the known risk factors are smoking, obesity, family history, and gum disease. Spondyloarthropathy represents a group of inflammatory conditions that affect the spine. And the most common one would be ankylosing spondylitis. Prevalence is about 0.2%. And this disease is very much a disease that affects younger people. The age of onset is usually between 17 and 45 years, and mostly presents in someone's 20s or 30s. There tends to be a male predominance of about 3-to-1. And the age of onset is quite important in spondyloarthropathy, in the sense that you can't be classified as having the condition if you have onset of symptoms before the age of 45. Or sorry, if you have it greater than the age of 45, you generally are not considered to have inflammatory back pain or to have spondyloarthropathy. So it's very much a disease that starts in youth. Systemic lupus erythematosus is a systemic autoimmune disease which can affect any organ. It typically manifests with arthritis and a photosensitive rash, and it most definitely is considered to be a disease of females mostly, with a 9-to-1 ratio, and it tends to come on around the age when women are childbearing potential, so between the ages of 15 and 44. And with our lupus patients, we are constantly kind of inquiring with them when they see us in clinic if they have any plans to conceive, because we know that pregnancy is a high risk time for patients with lupus, especially around the peripartum and postpartum period, when their disease is more likely to flare. So osteoarthritis then is the most common form of arthritis, and the prevalence is rising. This disease usually starts in middle age, around 40s or 50s, but it can start earlier if there has been previous joint trauma. So we do see this in athletes sometimes, and it's not unusual that we'll have patients come to clinic who may have had 2 hips replaced and they're in their mid to late 40s. But it's important to recognize that osteoarthritis is not an inevitable consequence of aging. And we see patients who are older in their 60s and 70s who don't have any evidence of osteoarthritis. The knee is the most commonly affected joint, followed by the hip and hand. We know that obesity is a major risk factor, and healthy diet and weight loss can not only help prevent the onset of the disease, but also can help alleviate symptoms in patients who have the disease. And there'll be further talks on diet and exercise later in this webinar series. And then lastly, juvenile idiopathic arthritis. So this refers to inflammatory arthritis that develops in children. And about 1 in 1,000 children in Ireland are affected. The onset can come on any time from 6 weeks up until 16 years of age. And if patients are diagnosed after that, then they generally get referred to an adult service and are classified as having an adult form of arthritis. It generally is more common amongst girls, but with the exception of a form called enthesitis-related juvenile inflammatory arthritis, where they get inflammation of the spine and tendon insertions. This is more common in boys. And in contrast to adults who present with forms of inflammatory arthritis, children don't always complain of pain, but they might develop a new limp, or they may develop a new loss of a skill or a new preference for using a limb. That is often how these patients present. So in terms of the goal of treatment, we have come a long way in rheumatology over the past couple of decades. Prior to the mid-90s, there were a lack of treatments to treat certainly inflammatory arthritis, and it was quite a bad disease to be diagnosed with. People had a shortened lifespan. They generally would accumulate damage as their disease progressed, and the treatments were quite toxic. And the goal of treatment back then was to alleviate pain and suffering. Nowadays, we have a whole armamentarium of new treatments that we can provide to patients, and really the goal has shifted dramatically so that we're now trying to help patients live a normal, fulfilling life. And one of the great privileges as a rheumatologist is to help patients achieve their full potential. And in terms of goals, those goals can be whether it's trying to study for their master's or achieve their educational goals. You know, some patients are involved in manual work and want to keep doing that, or involved in DIY. Patients' goals might be that they want to go on a holiday next week without having a flare, or they want to be able to go on that long walking holiday that they had planned to do last year. We help patients achieve their goals in their career by helping them to liaise with their employer, you know, if they need to attend appointments, or how to manage their flares and maybe adapt to their workplace. And then a lot of our women with female patients and male patients who come to us may be starting to plan a family, and we help them navigate that journey. And then also we have patients who are keen musicians who may have trying to maintain the functional ability in their hands, for example. And also we have patients who are keen sports people who want to maintain their sporting prowess. And it's great that we are now able to help them do all that kind of stuff. Arthritis Ireland, as Grania mentioned, runs a number of kind of courses and initiatives. And if you haven't signed up to a Living Well with Arthritis course, I'd strongly encourage you to do so. So this is a 6-week course that where patients are kind of taught about their disease, and they're given a variety of tools and techniques to help them self-manage their condition. And the feedback from my patients, certainly, that have done this course has been very positive, and it has definitely helped to empower them to manage their condition better. And the peer support that they get from it is notable. And also there are helpful pieces of information on the website to do with arthritis and employment, where they address lots of questions in terms of what are your legal rights if you have arthritis, how can you do a phased return to work, and issues regarding financing, access to benefits, etc. And there's also information available for employers that you can share with your employer about arthritis. And in addition to being able to help patients achieve their life goals, one of the other aspects of rheumatology that I really enjoy is that we really do see patients from the cradle to the grave. We see patients from all age groups. Our pediatric colleagues see patients who are young children and early teenagers, and then we see patients from the age of 16 upwards up to 90 or to late 90s, and so and very much multidisciplinary care is the cornerstone of how we treat patients. So we are in touch on a daily basis with physiotherapists, whether it's to do with core strengthening exercises or to try and maintain the range of motion of someone who has got inflammation of their spine, like ankylosing spondylitis. We have very strong links with occupational therapists and hand therapists who are able to fashion splints for patients if needed, and give them hand exercises to help them with daily tasks and give them appliances to help them with tasks. We obviously link in with dermatology because we share a cohort of patients, especially in lupus and psoriasis, who also have forms of arthritis. We have good links with orthopedics and plastics, and some of our patients, as time goes on, will unfortunately develop some joint damage in certain cases or recurrent tendinopathy, and sometimes surgical intervention can be very helpful. There's a growing awareness about an overlap with respiratory conditions, and some of our patients with rheumatoid and with systemic sclerosis, for example, will get interstitial lung disease. And many of us, including myself, do combined clinics with our respiratory colleagues, where we can see patients who have kind of comorbidities such as that together. Pediatrics then, they see patients with pediatric or juvenile inflammatory arthritis. And then as patients get older, we run transition clinics to help smooth that transition from pediatric to adult rheumatology care. And then OBS stands for obstetrics, where there's a growing awareness of a need for combined obstetric rheumatology clinics and obstetric rheumatology multidisciplinary meetings to help navigate patients when they are going through that journey of starting to plan a family. And then in gastroenterology, a lot of our patients with inflammatory bowel disease also have spondyloarthropathy, so we liaise closely with them also. So just to give you a few examples of the types of services that we provide for patients that kind of reflect the wide age spectrum that we see. So when patients are about to start a family, the preconception planning is very important. So we liaise closely with our obstetric colleagues to try and optimize disease control and ensure that the patient are on medications that are compatible with pregnancy. And then during the peripartum period or the pregnancy period, we monitor the health and mother of the fetus very closely. And then in the postpartum period, this is when rheumatologists are very keen to see their patients closely, because that's probably the time when patients are most likely to flare in terms of their disease. And then we have a growing provision of transition clinics. So these are clinics for patients who are transitioning from pediatric to adult rheumatology services. So this is often a daunting time for them. They're coming up to the age of doing their leaving cert. They might be trying to apply for college. They might be trying to get back into sport or excel in sport. And then on top of that, they're trying to navigate, friendships, social media, and really trying to navigate their independence whilst having a chronic disease. And moving from a pediatric setting, which they are familiar with, to an adult setting can be quite daunting. So transition clinics have been shown to help offer these patients more time that they need, so that we can focus on the challenges that they're facing. And certainly I learned from my pediatric colleagues, and I'm sure vice versa, from the adult rheumatology side in making that transition as smooth as possible. And one of the interesting aspects for rheumatologists is that because we see such a wide age range of patient, we kind of have to adapt our approach or tact when we are seeing patients at different age groups. So for example, younger patients in their teens and early 20s who come to us, their joints are still developing, they're still starting out in life, potentially they have another, 60, 80 years left of living, and therefore long-term function is important, and therefore we tend to treat patients more aggressively. So even if someone has mild synovitis in one joint, the inclination would be to treat that joint very aggressively to suppress all inflammation and prevent any joint damage from occurring. Conversely, then, as patients get older and maybe become more frailer and elderly, the focus should shift to more towards quality of life rather than longevity. And that whilst we should support short-term function, we have to be more considerate of the side effects of immune suppression. So, for example, frail elderly patients with multiple comorbidities will be more prone to infection. So therefore, we tend to take a more cautious approach when patients are reaching the later years of their life. So I'll just present a few illustrative cases. These are not specific cases, but more the types of patients that we could see in our daily practice. So the first patient is a 20-year-old male student who presents with a 6-month history of lower back pain and stiffness, difficulty standing up first thing in the morning. The pain often wakes him from sleep, and he finds that he's quite stiff in the morning, lasting for up to 2 hours. He gets relief with anti-inflammatories, and he's a keen swimmer, and he notices that when he's swimming, this helps his symptoms. So he's referred to a rheumatology department, and the rheumatologist finds that his history is consistent with inflammatory back pain and suspicious for spondyloarthropathy. So an MRI of pelvis is arranged, and here you can see on the right, this is his pelvis, and you can see that there's evidence of sacroiliitis. So this is the sacrum, and this is the iliac bone on either side, and the white changes here, that's bone marrow edema, which is bone swelling, and that's a very characteristic feature of sacroiliitis. So this patient is diagnosed with ankylosing spondylitis. He started on a long-term anti-inflammatory, which would be the initial first step that most guidelines recommend. And whilst he has some initial improvement, he develops ongoing early morning stiffness, limitation of activity. So then he is started on a biologic class of drugs called anti-TNF, and he has marked improvement of his symptoms. And simultaneously, as he's attending our practice, he is referred to our physiotherapy department, where he is able to engage in weekly classes for ankylosing spondylitis, which are specifically targeted for patients who have inflammatory arthritis of the spine. And the exercises are designed to preserve range of motion and flexibility. So the next case is a 31-year-old female civil servant who presents with a 4-week history of pain, swelling, and stiffness in the small joints of her hands, her right knee, and both elbows. And she is finding it increasingly difficult to type. Of note, she is a smoker of 5 cigarettes per day, and she's planning to get married in 6 months. So when she comes to the clinic, we find that she has a positive rheumatoid factor and CCP antibodies. So the CCP antibody in particular is very sensitive and specific for rheumatoid arthritis. And she also has a high CRP, which is a marker of inflammation. So she is diagnosed with rheumatoid arthritis. We strongly counsel her to stop smoking because we know that smoking is an independent risk factor for developing rheumatoid. And we also know that if you smoke, you're more likely to have worse disease outcomes, more likely to develop interstitial lung disease, and you're less likely to respond to treatment. And also, she's planning to start a family soon, so it's probably best that she stops smoking altogether. So we start our methotrexate, which is a disease-modifying anti-arthritis drug. And methotrexate would be kind of the gold standard medication to initiate. We refer her to hand therapy because she needs help at work and some adjustments need to be made to her work activity. Perhaps a splint might help, at least in the initial stages, until the inflammation in her hand settles down. And then we also refer her to our maternal medicine colleagues for preconceptual planning because she's getting married in 6 months and she says that she wants to start a family within the next year. So we kind of really need to optimize her disease control prior to conception. And then if she does want to conceive in the future, she would need to come off methotrexate for at least 3 months prior to getting pregnant. The last patient then I'll present is a 14-year-old male. He's a junior cert student and he is a keen GAA player. So he presents with a 2-month history of limping and has developed stiffness and restriction of the left hip. And although he doesn't have much pain, he finds that he's not able to play GAA anymore because he's unable to kick the ball as he was able to previously. And he's also found to have a sore left elbow when he tries to extend his arm. So when he goes to the pediatric rheumatologist, he has an MRI which shows this high signal intensity around the acetabular of the hip, which is the socket joint, if you like. So this is a hip effusion. This is a fluid around the hip. And this is something that we characteristically see with juvenile idiopathic arthritis, especially the enthesitis related form. And he is started on an anti-TNF agent with good improvement. And the reason for starting him on an anti-TNF early is because this is affecting a major joint, and we want to suppress the inflammation as quickly as possible so that we can try and prevent any damage from occurring and hopefully prevent him needing to have a hip replacement at a young age. He then is referred to the transition clinic because he's shortly approaching the 16 years of age at a time when he would be expected to transition to the adult services. And because he is able to be seen in that clinic and there is more time, dedicated to reviewing him, concerns are detected about low mood and anxiety, and he is then able to be referred on to a clinical psychologist and also to a dedicated physiotherapist for strengthening and conditioning of his hip joint. And then the last slide I'm going to talk about is prevention, because not only is arthritis a disease of all ages, but even for people who don't have arthritis, it's important that we kind of promote awareness about how we can prevent arthritis from happening. And there are lots of known risk factors that we can help modify. The first is to do with exercise. So core strengthening is really important that we should be doing throughout our lifespan. So this is strengthening our tummy muscles and our back muscles to help preserve our stature and to help lessen the impact on our ligaments in our spine and help prevent back pain as we get older. So the best forms of core strengthening would be through Pilates and yoga. But any kind of form of exercise will help to a degree. Weight-bearing exercise is very important for helping us to achieve our peak bone mass. So as we get older, up to the age of menopause in women and up to the age of about 60 in men, we are continuously increasing our bone mass until which stage our bone mass plateaus, and then that starts to drop off then as we get older. And if it drops off too much, then we get a condition called osteoporosis, and that can predispose us to low trauma fractures. So by engaging in weight-bearing exercise from a young age, we can try and maximize our peak bone mass. Diet is important, and I'm glad that there's going to be another talk about diet in this webinar series, because Ireland has a growing obesity epidemic, and this is most definitely contributing to osteoarthritis and also forms of inflammatory arthritis. Smoking is an independent risk factor for all forms of arthritis, and alcohol is a risk factor definitely for developing psoriatic arthritis, but it's also a risk for arthritis disease flares for all types of arthritis. So in conclusion, I hope that I've illustrated through various examples and clinics and services that we provide that arthritis very much can affect all age groups, and it is a disease from the cradle to the grave. I'm very lucky to work in an area that there has been so much advancements in terms of therapy that now, the goal is to help patients live fulfilling lives and achieve their goals. Multidisciplinary care is very much the cornerstone of the care that we provide. And Arthritis Ireland provide a number of supports, and especially want to flag the Living Well with Arthritis course that is provided and is a great benefit to patients. So thank you, and I'm happy to take any questions.
Thank you very much, John. That was really interesting and very insightful. And we have a lot of questions coming in. So I'll kick off some questions for you here and you can take them.
Yeah.
So the first one is, can children who are diagnosed with polyarticular JIA with a positive rheumatoid factor have periods of remission? And are they likely to remain on medication into adulthood? Sorry.
Yeah, so it's a good question. Yes, they can have periods where they are disease-free, or it's a relapsing remitting condition. So most types of arthritis inflammatory arthritis are characterized by disease flares. And with treatment, the idea would be to get people into remission. With juvenile idiopathic arthritis, there is a proportion of patients who will go into long-term remission. The disease kind of burns out. But we still tend to follow those patients because what we have found, I think, and there's a growing awareness that patients with juvenile idiopathic arthritis can have subclinical inflammation, so that it may not be as manifest as someone with adult onset disease. So we still tend to follow them as they get older.
Okay, great, thank you. There's a question here about perimenopause and arthritis. So there's a person who's wondering if they have symptoms that sort of seem to overlap. Should they see a rheumatologist or should they see a women's health doctor? They're just wondering what the best way to go is if they've overlapping symptoms that are difficult to differentiate between both.
Yeah, I would say see both, actually. Certainly anecdotally, we are seeing more women being treated for symptoms of menopause than have been in previous years. And anecdotally, patients have come to me saying that they had osteoarthritis can come on around the time of menopause, and it can be quite inflammatory in the initial stages. And anecdotally, about patients saying that they started on HRT and that their symptoms got better. So I think if you're having significant menopausal symptoms, it's worth talking to a women's health specialist about starting treatment for menopause. For hand osteoarthritis in particular, which tends to come on around menopause time, short courses of steroids for a few weeks can be helpful if the pain is pretty severe and the joints are hot and swollen. But usually it subsides, and we usually kind of prescribe symptomatic treatment with simple analgesia or topical anti-inflammatories. But if they are having persistent symptoms, it would be worth getting seen by a rheumatologist.
Okay, thank you, John. Another question here about psoriatic arthritis. There's somebody who has chronic sacroiliitis and nail pitting, and they're wondering what treatment options there might be there for them.
So the great thing about psoriatic arthritis is that it's probably the disease that has the biggest range of treatment available. So there's biologic treatments, which are injectable drugs that you take on a weekly, fortnightly, 3-monthly basis. There is the standard drugs like methotrexate and slazopirin. There are topical treatments for arthritis. If that patient has sacroiliitis, then he or she probably needs a biologic drug, because they are the only drugs that have been shown to be effective. So you definitely would need to see a rheumatologist. So the options would be either an anti-TNF agent, IL-17 agent, or sometimes an IL-23 agent.
Okay, great. Another interesting question here about family planning with arthritis and specifically RA. Is there any consideration needed about passing on the disease to children?
No, generally not. I mean, family history is a risk factor for developing rheumatoid, but it is not considered to be, a genetically inherited disease. So it's not something that we would do genetic screening for. And your children may carry the genetic predisposition, but they may not go on to develop the disease. So I think, things like not smoking and, can help them not develop it. But it's not considered to be a genetically inherited disease.
Okay, thank you. A good question here about surgery options for somebody who has arthritis in their shoulders, and they're wondering if that's a possible option for them. So surgery of the shoulders, is that something they might be able to consider?
Yeah. So we see patients with shoulder problems a lot. So we see people with rotator cuff tendinopathy, and then that can progress to rotator cuff tears. We also get bursitis in the shoulder, and you can sometimes get, synovitis, large joint effusions from inflammatory arthritis. With regards to shoulder surgery, sometimes if you've got a lot of tendinopathy, a shoulder surgeon can do what's called a decompressive washout, where they kind of do keyhole surgery and they kind of wash out any inflammatory tissue, and that can help settle down the joint. And then if someone has had a full thickness tear of their rotator cuff and they can't lift their arm up beyond 90 degrees and they have a lot of pain, the orthopedic surgeon can do what's called a reverse shoulder arthroplasty, which is a type of shoulder replacement. But the goal in that situation is to reduce pain, but unfortunately you don't get any recovery of function, not much recovery of function. But that can be a good option if someone has chronic pain in a shoulder that has had a complete tear of the rotator cuff.
Okay, great, thank you. We have another question here about physical work and osteoarthritis. For somebody who is just diagnosed with arthritis in their shoulders and they're working in a very physically demanding job, can the progression of the disease be, slowed down if they change careers? They're quite frustrated, but they're considering a different career type of work. Would it be helpful for them to consider something like that?
Yeah, I mean, sometimes we do see people who are doing very manual work, and there's definitely a clear pattern whereby when they go to work, their symptoms are much more severe. And then when they're on holidays or they take a break, everything settles down. And I suppose with osteoarthritis, there's no, targeted treatments that can, eradicate the disease, and it's kind of tailored around symptomatic management. Some patients do okay if they are very well engaged with a physiotherapist and they're able to maintain kind of strength and mobility exercises in their shoulders, for example. But if you're doing really heavy manual work, then it probably is going to burden the joint and make things worse. So it is something that each individual patient has to consider about, changing their type of work.
Okay.
In that situation. Yeah.
Yeah. What are the implications of steroid injections for arthritis, and can they be given on a regular basis?
Yes, so we do see patients and we inject their joints periodically. We try not to do it more than every 6 months. And the reason for this is that there is a very, very small risk of introducing infection. And the more often you do that, the higher the risk goes up. So we try to aim for on a 6 monthly basis, and that seems to be a safe recommendation.
Okay, great. There's a question here about pregnancy and delivery when somebody has arthritis in the pelvis due to hip dysplasia that was treated in childhood. It wasn't treated properly. So they're wondering, would it affect the delivery for a baby?
That's a good question. And again, that's a reason why someone like that should attend like a maternal medicine clinic where they can preempt those kind of questions. I guess they would look at any previous imaging, the range of motion of the hip and pelvis, and I guess they would see how the lie of the fetus is progressing during the pregnancy, and then they'd have a discussion about options with the patient well before the due date. So I guess in some circumstances, if it was felt that it was going to be that the dysplasia was going to give rise to a difficult labor, then they probably would go for a cesarean section.
Okay, great. Thank you. Would you have any advice for people who are living with arthritis and struggling with disturbed sleep, which is having a knock-on effect then on pain levels and being able to eat well and engage in exercise?
Yes, we see this a lot as well. So I think the first thing would be really good sleep hygiene. So, no coffee after midday, for example, or no caffeine, making sure that they're kind of winding down early in the night, avoiding being on their iPhone or tablet before they go to bed, doing any kind of thing, that relaxation technique that might help them going to sleep and going to bed well before they intend to go to sleep. If they're taking steroids for their arthritis, then they should try and take those medications first thing in the morning as opposed to last thing at night, because they will keep you awake at night. And then the other thing that's been shown to help sleep, which can be a challenge if someone has arthritis, is aerobic conditioning. So the more aerobically fit you are, the better that you will sleep at night. And then, failing all that, sometimes we do prescribe medication, like amitriptyline, for example, which is thought to help improve the quality of sleep. But I would usually recommend to patients to try natural remedies first.
Okay, great. Thank you very much. Is there a limit to the length of time that somebody can take biologics? Don't think there is, but maybe.
Yeah, I mean, they have shown to be quite safe. They've been around, but the anti-TNF agents are around for nearly 20 years now. And the good thing is that there are lots of worldwide long-term open label studies, registries, where they've followed up the real world happenings of patients on these medications over a long period of time, and they do appear to be safe. I think when they become unsafe is perhaps in later years, when people have lots of comorbidities and may have like a chronic lung disease that predisposes them to infection, and then we add in a biologic on top of that, it makes them even more susceptible to infection. So that would be the main concern that we have, but in general, they seem to be safe in the long term. Yeah.
Okay. And then I suppose to follow on with that question, then there's a query about how long it would normally take for biologics to have an impact and to start working. I'm assuming in terms of pain as well as other factors, but it seems maybe that.
So the benchmark is usually hopefully you expect to see something by the 6-week mark, and then you definitely something by 3 months, and then the maximal efficacy by 6 months usually.
Okay, that's fairly good. Let's see, is there any connection between enthesitis and psoriatic spondyloarthritis? And can the arthritis be in remission, but the enthesitis suddenly become an issue, and how is that treated?
Yeah, so patients with psoriatic arthritis can get what we call polyenthesitis, and that can be harder to diagnose and treat because often it's not that visible. It's where you get inflammation where tendons insert into bone. So often, typically, the sites would be the elbows, hips, and the back of the Achilles tendon. So that certainly can flare up if, say, someone's large joints have settled down, or if their sacroiliitis has settled. You can get a flare of polyenthesitis, and we would treat it the same way as we would, say, sacroiliitis. We'd treat them with disease-modifying drugs like methotrexate, and if those weren't working, or if the patient didn't tolerate them, then we'd go to a biologic.
Okay. There's somebody here who has a query about diagnosis. They seem to be getting kind of confusing messages. So they've had a diagnosis of RA, then they got a second opinion, which was changed to undifferentiated connective tissue disease. But they have some ankylosing spondylitis symptoms, and they're wondering if they should have an X-ray and get the HLA-B27 gene test done, if that would be recommended.
Yeah, so it's with rheumatology. Sometimes we see patients and the diagnosis can evolve because they may not meet all the criteria for one particular disease. And or you might get a false positive antibody or a low titer antibody. So for example, the rheumatoid factor, sometimes GPs will test for that and it'll be just mildly positive, and the GP will think that that is a significant finding, whereas the rheumatologist won't consider that to be significant. In terms of the HLA-B27, it can, if inflammatory back pain is suspected, so this would be a young patient who has got early morning stiffness lasting for at least 30 minutes, pain waking them up at night, and stiffness in the mornings, a HLA-B27 that comes back positive can, I suppose, increase the likelihood that you have spondyloarthropathy, but it's not diagnostic. X-rays of the sacroiliac joints are good if you've had established disease, but often you need an MRI scan to detect sacroiliitis when it first starts to present.
Okay. There's another question here about somebody who's unable to take anti-inflammatory medication due to kidney issues, and they're in quite a bit of pain with osteoarthritis, and they're trying to engage in exercise. They're just wondering what other options might be available to them.
Yeah, I probably would say like if paracetamol is probably not, if it's not helping them, then you could try something like a compound analgesic, so something like Ixprim, which has a little bit of codeine or tramadol. I can't remember which one. There's another one called codamol, which I think is a slightly stronger version of paracetamol. So you could certainly try those. Yeah, and then the other thing you could try, I'm just thinking out, capsaicin cream sometimes can be helpful for joints. It's chili based cream. It gives off heat to the joint, and some people find that gives them some relief when they're exercising.
Okay. Then another just question about inflammation in the gut, and is that linked to RA? Is there a connection between the two?
So there is definitely a link in terms of spondyloarthropathy for sure. And there probably is a link between lots of diseases between the microbiome, and that's kind of been studied across all disease groups. But as far as rheumatoid is concerned, I don't think they've found anything definitive, if you like. But there's definitely a link between spondyloarthropathy and the gut for sure.
Okay. Another question here, and I think it's probably a kind of a fairly broad question about depression and anxiety. Is it something that's connected to RA, or could it be a response to pain and fatigue? I think there's probably a risk factor there overall.
Sorry, what was the question again? Sorry.
So the question is depression and anxiety, is it caused by RA, or is it in response to the pain and fatigue?
Yeah, it's a good question. I think depression and anxiety is definitely more prevalent in rheumatoid patients than patients without rheumatoid. And I guess there's probably a combination of factors at play. There's probably an adjustment period where you get diagnosed and you're kind of, coming to the terms of living with a chronic disease and learning how to self-manage it. Pain and it can obviously lead then to temporary loss of mobility, temporary problems with sleep, and that in turn then can affect our ability to do the things that we enjoy, to exercise, and to do the well-being things that we enjoy doing. And I think that can lead to low mood and anxiety. So I think it's definitely worth speaking to your rheumatologist or GP if that is the case, and getting some support. Okay.
Then I think we'll probably finish off shortly, but one question here just about a person who is experiencing pain and their father has psoriatic arthritis, but they don't have any psoriasis. Is it possible that there's a link there and that they should run some tests for psoriatic arthritis?
Yes, that's a great question. And the answer is yes. So a family history of psoriatic arthritis is a risk factor for developing psoriatic arthritis, and you don't need to personally have psoriasis. It does, yeah.
Okay. Yeah. Okay. Let me see. There's a question here about somebody who's in their 20s and lives with ankylosing spondylitis, which is under control and well managed, but they want to go traveling with friends for a year. Is that advisable?
Yes. So if you go, so ankylosing spondylitis, some patients do very well with just exercise alone and anti-inflammatories, so they don't need to be on biologics. But if that person was on biologics, I would suggest speaking to your rheumatologist, and usually the rheumatology department will give you a letter to bring to the airport, which will allow you to bring your injections onto a plane. Now, if you're going for a year, you might need to figure out how you're going to get your prescription when you go abroad. So you might have to check in with a rheumatologist at the 6-month mark if you're going away for a year to a private clinic. So you want to have good health insurance, obviously. And you might need to get your prescription abroad and plan that in advance. But we do see patients who end up traveling with the condition. Yeah.
Yeah. So just some planning involved,
yeah,
really.
Planning, yeah. Exactly.
Yeah. Great. I think that's all we have time for. John, thanks very much. That was a fairly intense Q&A, so appreciate you being able to answer all of those questions so well.
Thanks for having me. Yeah.
I'll hand you back over to Grania now.
Okay, thank you so much, John. I just have a few slides there to share at the end, so if I can share them, you might stop your sharing there at your end, John.
Okay, sorry. Yeah. Let's see. Stop share.
Great, thanks so
Yeah.
much. Few things here to just cover off. Look, thank you again to Dr. John Stack for your time over lunchtime. So I really appreciate that today. I think everybody online will agree that it was very informative and really helped us dispel that myth that arthritis is just an older person's disease. So thank you very much for helping us dispel that myth. Just a reminder again, I mentioned this at the top of the session, but we do have 2 further webinars coming up this week. So they're both at lunchtime, so both 12:30 starts. The first one is physical activity, exercise and arthritis, so that's tomorrow. And that's with Professor Helen French. So, you know, we talked about physical activity and exercise today. So come online at lunchtime tomorrow to find out more about that. And then also on Thursday at 12:30, we have the topic of arthritis and food. Okay, so I think that's one of the ones where there's certainly lots of myths that we need to dispel. So Louise Reynolds, who's a registered dietitian, will be on that one at 12:30. Okay, so do register at arthritisireland.ie for those. Move to the next. Will let me. Yeah. Want to just also thank our sponsors, AbbVie and Novartis, who are kindly supporting all of our activities during National Arthritis Week and these webinars, of course. I mentioned at the top of the session as well that, you know, obviously as a charity, we do rely on the generosity of the public to ensure that, you know, we can continue to provide our essential services and support. So if it is possible, it would certainly be wonderful if you would consider donating during National Arthritis Week. And you can do so by scanning that QR code that's on the screen, or you can visit arthritisireland.ie and use the donate button on that. And as I said as well earlier, we are looking for women, so women for the Women's Mini Marathon, and we certainly heard John talk about the prevalence of arthritis being higher nearly across all types of arthritis, unfortunately. But we'd love to see a team of women representing Arthritis Ireland join in the BHI Women's Mini Marathon on Sunday, the 2nd of June. As I said, I'm doing it myself, so I would love some company. And you can register at arthritisireland.ie. And just remains for me to thank you and to just remind you of our website address and our helpline number there, 0818 252 846. Thank you very much to everybody for joining us today, and a special thanks to Dr. John Stack for a really interesting talk today. Thank you so much.